Good afternoon, everybody. Um, yes, so welcome to the Kisa webinar. It gives me great pleasure for today to introduce you a friend and colleague, Dr. Anthony Reid. Dr. Reid is trained in anesthetics in the UK as well as South Africa and started his specialty career as a lead for neuro anesthesia at Grooteskier for 6 years before he took up an additional 50% contract position as the provincial coordinating clinician for anesthetic services in the Western Cape. This cross-sectional view has afforded him a very unique insight into medical equipment, the running of facilities, staffing, skills, and the workload of the health department. This unique insight has proven him to be extremely valuable to the infrastructure and health technology directors as an advisor, and where he also serves as an advisor for the medico-legal unit. Dr. Reid is currently the head of anesthetic department at New Somerset Hospital and also the level 2 head for theatres and anesthesia in the western half of the Cape Town Metro. Additionally, he remains the lead clinician for neuroanesthesia at the Grooteskier Hospital. Dr. Reid has a special interest in medical equipment and also serves as the lead clinical advisor to the Departmental Equipment Committee's medical equipment stream for Western Cape Department of Health, where his experience and his unique outlook is extremely valuable. Dr. Reid is also a senior lecturer at UCT on anesthesia and perioperative medicine and served as an examiner for the FCA specialist exams from 2005 until 2022. Dr. Reid, thank you for sharing your knowledge and experience with us today. Over to you.
Okay, so yeah, thanks a lot, guys, for asking me to chat. I was given basically free rein to pick a topic, and I've picked something that's been sort of a bugbear of mine. So I've been in anesthetic practice for 34 years now, so I thought one of the things that really gets to me is I think that anesthetic monitoring hasn't really advanced much in my 3 and a bit decades in anesthesia. And so I thought, let's have a look at that and make some suggestions. So what I'm going to do is I'm going to give you an opinion. So there's going to be a little bit of fact and science behind it. But really what I'm going to give you is not it's my opinion only, and it's not really what everybody thinks, but I think hopefully you'll learn something and it'll make you think at the end. So where have we come from? So monitoring as we know it now, and as if you might walk into an operating theatre now, was not always like this. This picture by Dorothy Kay, who was a Port Elizabeth-based artist, was made she painted in 1937. And this is a patient having a cholecystectomy at the time. And you can see the anaesthetist there. He basically has a very, very rudimentary collection of anesthetics. And he has got his hand on the patient, probably feeling their pulse in the neck. And he's got a Schimmelbusch mask that they're breathing through. And he's probably looking at how they're breathing and the color of the patient. And that's what it was like then. And it wasn't that long ago. And if you look at when our different monitors became commercially available, the automated non-invasive blood pressure only became available in 1976. The peripheral nerve stimulators followed in 1980. In 81, we got peripheral oxygen saturation for the first time. Capnography in 1986. And in 1990s, the standalone anesthetic vapors that fitted on the anesthetic machine became available, and disposable transducers around that time. And in 1996, although the processed EEG or BIS monitor was licensed by the FDA, it wasn't licensed for monitoring depth of anesthesia at that point. And that was only in 2003. So the monitors as we use them now really are not that old. And if you look at the automated blood pressure, the non-invasive blood pressure, which the automated blood pressure measures, was first described in 1905. It's just over a century ago by Korotkov, the Russian surgeon. And he described, as we measured with a bowmanometer with our stethoscope on an artery, and we would listen still for what are called Korotkov sounds. And not that long afterwards, in 1930, von Recklinghausen developed the oscillotonometer, which was a dual cuff system, one a sensing cuff and one a measurement cuff. And the nice thing about the oscillotonometer was that you could measure the blood pressure, the systolic and the mean, by just using one hand to blow up the bulb and to let the air out. And that allowed the anesthetist to do something else. And so a lot of the early anesthetic machines had von Recklinghausen's oscillotonometers actually built into the machine with the dial on the machine. And the anesthetist had quite long pipes that they could then have the cuff on the patient, and they were quite mobile around their machine. But in 1976 was the first automated non-invasive blood pressure. And only in preparing for this presentation did I realize that DYNAMAP is actually an acronym for the Device for Indirect Non-Invasive Mean Arterial Pressure. And it was developed by a company called Applied Medical Research. And they used the very first Intel microprocessor in that DYNAMAP. And then that company was then sold to Criticon, which was then bought by J&J, and now is in the hands of General Electric. So that's kind of the history of DYNAMAP, and the name still lives on. Invasive blood pressure, interestingly, was measured first in 1733 by a guy called Hales, as he's shown in this picture on the right, with him measuring the pressure in the neck of a horse using a column of blood. And that was exactly the kind of measurement that was used when they did the first heart transplant at Curtis Care in 1967. They used what's called the giraffe, and I'll show you a picture of it in a moment. In the 1980s, we started using reusable transducers, and the 1990s saw the widespread use of disposable transducers. In terms of capnography, in the very early 1900s, Haldane measured that he knew they used a technique where they could absorb CO2 and measure the difference in pressure, and they knew the volume had changed. And that's how they first of all started to work out the volume or the percentage of CO2. But in the 1930s, they started using infrared, which is what we use now, but they used different technique. They used an acoustic technique at that point. And then in 1930, Raymond described the scattering of ultraviolet light and a slight absorption by different gases, and they were able to measure CO2 as one of them using that. And he's an interesting guy because he was the first person from the Asian continent and the first non-white person to win the Nobel Prize for Physics in 1930. And he was so sure that he was going to win the Nobel Prize for this idea of Raman scattering that he booked the ticket on a cruise liner or a boat to go to Stockholm long before the prizes were announced for him and his wife, because then he knew he'd have a ticket. Otherwise, he wouldn't be able to get a ticket. But that aside, in 1978, the first clinical capnography was suggested, and there were 5 anesthetists who went to that meeting, and they weren't really that enthralled with the idea. But by 1981, mass spectrometers had been introduced into the big operating rooms in the United States, and they could measure carbon dioxide. And in 1986, the first mention of end-tidal carbon dioxide is mentioned in the monitoring standards developed by the American Society of Anesthesiologists, And it was only described as an emerging standard there. So 1986 is not that long ago. Peripheral oxygen saturation also has a long history. It was in the 1860s, they first worked out that using spectroscopy, they could describe what oxyhemoglobin looked like. And then in the 1920s, Millikan used two wavelengths in a colorimeter, which is very similar to the principles used in modern pulse oximeters. And he was able to quantify how much oxyhemoglobin was in blood based on that. And then a long time went past before the Japanese guy, Taku Ayagi, I think, developed non-invasive pulse oximetry in 1974. And really that was a breakthrough. So he developed the ability to detect the pulsatile component and to then measure the quantity of oxyhemoglobin in that. And that was using 2 different wavelengths, 660 and 940 nanometers. And in 1981, we got our first pulse oximeter. So they are everywhere now, but there wasn't a single pulse oximeter available before 1981. And then in 2005, we got multi-wavelength co-oximetry, which gives us much better information about different types of hemoglobin and gives you a measurement of hemoglobin. So this possibly one of the greatest advances in anesthesia care is the introduction of pulse oximetry. And in the developed world and even in large parts of Africa, they're widespread, but there are places in the world where they still give anesthetics without pulse oximetry. So the anesthetic vapors, they were not able to be measured until they developed the mass spectrometer in 1981. So before that time, there was no way of knowing what you were inhaling or what the patient was inhaling. At around the same time, the Philadelphia Plate Glass Company developed a system called SARA, the System for Anesthetic and Respiratory Analysis. It was around for a short time, used a different kind of technology, and disappeared. And it wasn't until the 1990s, until the standalone infrared multi-gas measurement tools that we have now were developed. And other forms of technology can do it, like Raman spectrometry. And there's a piezoelectric technique and also the photoacoustic infrared technique, but they've all fallen away. So we now basically have the infrared measurement of it, and it's miniaturized into these tiny little modules that slot into the side of our monitors. So it hasn't been a long time that we've been able to measure it, but nowadays we have these tiny little boxes that give us an enormous amount of information. In terms of disposable transducers, I promised you I'd show you a picture of the giraffe, and this is the giraffe in the museum in our chirurgical department, and it goes from the floor almost to the ceiling. And it has a column up the middle that they would put some methylene blue in, and that would then signify the pressure, and they would zero this plate that's about a quarter away from the floor at the level of the patient. And that's how they measured the blood pressure, the invasive blood pressure, at the time. And that's what happened. That's how they did the first heart transplant. There was no better way to measure the blood pressure, because you can't use a non-invasive blood pressure machine because there's no pulsatile blood pressure when you're on cardiopulmonary bypass. So this was the only way to do it. And the interesting thing about the giraffe is just below the second lot of hooks down is that there's a neck there that you can bend it over so you can get it through the door, and then you can stand it up again whenever you get to the ICU or to theater, wherever you're taking the patient. But when I started anesthetics in the early 1990s at Grooterskeer, I'd been in the UK before that, but they were using these reusable transducers in the top right here. And you would look for a dome that they would be sterilized, and then you would put a dome on top and bleed the fluid through and get rid of the air. And then you would use that transducer, and then afterwards you'd clean it, and then it'd be used on another patient. And then single-use transducers have obviously come in and make it so easy for us, and much better for the patients, I think, because they're not reused. Peripheral nerve stimulators are a tiny piece of equipment that are absolutely critical to anesthetists, and they have an interesting history, and it took us a long time to get to where we are now. So the first time curare was used was by Harold Griffiths in 1942, and by the 1950s there was widespread use of these neuromuscular blockers. But it wasn't until 52 where anybody decided to actually look to see how they were working. But he didn't actually look at the non-depolarizers. He looked at the depolarizing muscle relaxant, succinylmethonium, and he described it using a myograph. And then in 1958, two anesthetists, Christie and Churchill Davidson in London, developed a nerve stimulator very similar to modern nerve stimulators. And they used it, though, not to measure how deep the block was. They just wanted to be able to measure when patients weren't waking up or breathing adequately, had they received too much opiates, or were they still paralyzed? And so they just had this binary thing. It wasn't really used at all to monitor the depth of the block or to make decisions. It was really to work out why patients weren't waking up. Interestingly, not that long afterwards, the physician started using a train of 4, which is in the new modern nerve stimulators, to assess how well patients with myasthenia gravis were responding to treatment. So it wasn't anesthetists who were using the train of 4 initially at all. And in 1970, Ali et al. Used it with neuromuscular blocking agents and predicted that there was going to be a future use for this. But it wasn't until 1980 when Vigby Morgeson, who's a big name in neuromuscular blocking agents and the history of them, described a modern nerve stimulator with the twitch and train of 4 and a TOF ratio and a post-tetanic count like we use now. But it's interesting because at the time, from that time, more and more it became important, and it was included in all standards that every time you use the neuromuscular blocking agent, you should use a nerve stimulator, particularly with regards to deciding when to reverse the patient and when the patient was reversible and when the patient was suitably not paralyzed to look after their own airway. But anesthetists failed that test, and what happened is that over time, very bad practices crept in, And then with the new reversal agent sugammadex, anesthetists basically became lazy. And what started happening around 2010 to 2020 was that we actually started to see poor outcomes because patients were not properly reversed after their anesthetics. And this led to both sides of the Atlantic, Europe and North America, coming out not only with a policy statement, but with what they call a professional practice change initiative. And it involved pretty pictures like the Twitch monitor in the middle there, and lots of interventions, and also a standard that required every operating theatre once again to have a nerve stimulator in the operating theatre. And what they showed is on this graph on the right is the percentage of patients before 2020 who had a documented trainer 4 ratio was somewhere around 1 to 3%. And as they implemented this practice change initiative, that has gone up to where it should always have been, around 93 to 95%. So they've made a big difference, and it just shows how bad practices can creep in, not just in one place, but actually around the world. So depth of anesthesia monitors are interesting, and they are quite topical at the moment. So we've known about the electroencephalogram changes that general anesthesia causes since the 1950s. But the problem was that they all rely on a Fourier transform of a complex waveform, like next to the 35 and the BIS monitor on the right here. And you need to know that waveform, what are the wavelengths that are making up that complex, or the frequencies, and what are the amplitudes of the waves making up that trace. And so it requires quite a lot of data processing, and that just wasn't around for bedside use until around 1996 when BIS was first licensed, and then it was relicensed for targeting depth of anesthesia in 2003. But it's an interesting thing, this because these process EEGs measure the frontal EEG. So they measure the surface brain waves on the frontal cortex, and nobody thinks that anesthetics act on the frontal cortex. And it's similar to the MAC. The MAC is the minimum alveolar concentration that we use to compare the potency of different agents. And it measures how much of an agent you need to stop 50% of the population moving in response to the surgical stimulus. And that measures just a spinal cord reflex. But we correlate that with what the state of general anesthesia. And so what you have here is you have a spinal cord reflex and one frontal lobe surface EEG. Neither of them are where anesthetics actually produce their action, but these are the changes that occur at the time that we think that we have adequate anesthesia. And then what we've got now is we've got things that are marketed based on that kind of thinking. And so what they've done with the BIS and quite a few of the other manufacturers have subsequently followed, they've developed this density spectral array. And that's this colored chart that you see on the bottom right of the BIS monitor here. And really what they've done there is they've taken a 3-dimensional state, like on the left here, where you have time on the right-hand axis, frequency on the left-hand axis, and the power, the amplitude of the waves on the y-axis. And what you see here is that in the wake state, in the front edge of that, is that there's no dominant wave. I think you just need to ignore this. This is some artifacts that occur here. But what happens is, as they increase the depth of anesthetics through here and then turned off the anesthetics, what you see is that you see these initially in the 20 to 30 hertz wavelength, the amplitudes, or the frequencies rather, the amplitudes increase, and then the amplitudes increase in the slower wavelengths. And these are real slow wave amplitudes here of a patient who's deeply anesthetized. And then when they turn it off, you see the loss of these ones, and then the higher frequency ones, amplitudes increase, and eventually there's no real dominant one. This is a bunch of artifact here. So what they've done is they've tried to take this 3-dimensional thing and they've changed the amplitude or the power of each frequency, which is up on the y-axis. They've made it color, they've depicted it in a color, and so that red is the bigger amplitude, orange less so, blue less so. So that's what they've done there. And at the moment, there's a lot of interest in density spectral arrays. The problem is behind that, you have to see the picture or the graph on the left, and behind that, you have to realize that actually there's a Fourier transform that gives you that data per second. And so it's interesting. The evidence for how you read it is not fantastic. I had another look this week. But I'm hoping with lots of people being interested in looking at this, that we may well land up having a breakthrough in how we interpret these brainwaves and the depth of anesthesia. So it's an exciting area, but at the moment I'm in the group that's a bit skeptical of DSAs. So that's where we've come from. But I want to say is that what haven't we done? So I don't think we've moved away a lot from those things. We've developed these monitors and we've stacked them up, and that's how we've been using them. Our theaters are full of cables and wires, and we're forever untangling them and getting them stuck around various things. Our alarms are really basic. In fact, they're quite ancient in how you set them. And we just haven't adopted any better form of presenting the data that we have, and we haven't gone hands-free when other people have. So in people giving anesthetics in the 1980s, this would be a common sight. You'd have a ECG, or for defib, you'd have a SATS monitor. You might have a capnograph if you were lucky. There's no ways you even had an agent analysis device then. And really, as machines got a bit more fancy, nothing really changed that much. So the machine on the right, I quite like this. People would have been very happy with this in the early 1990s. Really, they had an ECG, SATs, and a blood pressure on a Pro 1000 up here. They had a spare SATs monitor, an agent analysis, and they had a machine that didn't have a selector tech bar. They could only give one type of vapor on it, and they would have been pretty happy with that probably. And now the modern machines, they all look like this, and we have these fantastic monitors that can do all sorts of things, we think. But if you step back and think about it, each monitor is really just sort of a dynamap, a capnograph, an agent analysis, an ECG, and then you might have an invasive blood pressure and some temperature sensor. And they just almost stacked on top of each other they basically just give us a rhythm strip and a value, and we can set basic alarms. And we really haven't moved much forward at all. We haven't gone wireless. So I was at the Bryan Adams concert 3 weeks ago, and I was intrigued to hear them. Is that the sound comes out? But I want you to look at their guitars. So if you look at them, their microphones, interestingly, have got cables, but their guitars are completely wireless. And yet the music is what it's all about. So they're brave enough to go that way. And there's so much else in our lives that are wireless, and yet we haven't managed to go wireless. So this is our operating theaters yesterday. I asked my juniors to send me some pictures of what their theaters were like. And this is the kind of stuff that lies around heading towards the operating theater bed from the anesthetic machine. And I just don't understand why we haven't had manufacturers explore this more. I mean, the technology is there. The signals that we have are simple, and the distances are very small. So I really do ponder why we haven't changed this, and it's a constant niggle for us. We also haven't changed our alarms. So we don't have intelligent alarms. We just basically set minimums and maximums, and they just go off whenever they want to otherwise. So if you're in an aircraft cockpit, they have different inhibitions and filtering for different stages of the flight. So during critical flight phases like takeoff and landing, non-essential warnings are temporarily inhibited during those phases. So they don't distract the pilots from much more immediate and more important things that they need to focus on. And then the modern systems, not only do they stop alarms, but if alarms do occur, they don't set off a whole lot of, because often when one thing fails, then something else will happen as a consequence of that, and something else happens as a consequence of that. So you might have 3 alarms telling you about the same thing. They've also stopped that, so that if you have for us, if you have an airway disconnect, we will lose CO2 and we'll lose airway pressure, and then the ventilator will tell us it's not ventilating. And actually what you need to do is only one of those probably needs to go, and it's the root cause. So they've also worked their alarms that they're much more intelligent than ours. And for me, the classic example is the anesthetic machine during a general anesthetic. So during a general anesthetic, we start the induction, we get the patient deep enough, and then we're either going to put in a supraglottic airway or we're going to use the endotracheal tube and intubate the patient. And at that point, we then put the airway down, the mask and the airway circuit, and now we have to work with the patient's airway. And then what always starts happening is that the capnograph tells you there's no CO2 and starts alarming, and then it'll say there's no pressure, and we have to ignore that. And then once we've done that, we then connect it up, and then the anesthetic proceeds, and then there's a long period where it's really important that you have a disconnect alarm, that the CO2 and the pressure would tell you that. But then at the end of the anesthetic, it's predictable. We need to get those airway devices out. So at some point, we are going to remove them, and the CO2 is going to stop. And every time when we do that, the machines then tell us that there's a CO2 is not coming out and there's a loss of pressure. And so we have alarms that don't take into account at all what we are busy doing, and they tell us things we know about, and they actually just get in the way. So, I mean, I don't know why we haven't changed these things. We also haven't changed how we represent that data. So what we do is we basically get a SAT strip, and we get a capnograph, and we get the values, but we're not presenting it any differently. And this recent review, well, not that recent, it's 2020 rather, really summarized what had happened over the last 2 decades in the kind of critical care environment. And what they showed is that there are quite a few studies that showed that if you use graphic displays differently, is that you got better attention from the physicians and better treatment options as well. And what they showed is that 12 out of 16 studies showed improved detection and response time to events if they were represented with digital graphics rather than just a numerical value. And 10 out of 16, not only did they detect it, but they actually land up improving the accuracy and the efficiency of treatment. The problem is the numbers are relatively small in these studies, but they include a lot of anesthetic data as well. And they haven't caught on. And the reason they haven't caught on is because we're humans. And, you know, they tell you when you're young, you must start saving for your pension. We shouldn't pollute the environment because it's going to have environmental impacts. We should always wear seatbelts and not drive on our mobile phones. And yet we all end up doing this. And it's the same with us. There's been a great resistance to change to a different form of data than the one that we're so used to, which is just stuck in waveforms and numerical values. And as I said, I've got a bugbear about the alarms. I think inside what is supposedly an integrated monitor is actually just a stack of old monitors, but it's just given to us in a different fashion. And then the things that we are promised that are so much better about monitoring are things like we get printouts of our data, we get automated records, and then the companies will tell us that they'll network. All of the stuff can be networked into big data caches, and then people can use that. And I put it to you that patients don't care about any of that. All the patients care about is, did my medical staff make sure I had the very best outcome? Did they use the best equipment and drugs? And did they respond appropriately and timelessly to any variations? And I'm not sure that we're helping them to do that anymore by promising them things like big data, automated records, and printouts. It's all historical stuff that it doesn't help you in the moment look after your patient. And so this is why I think we need to consider moving towards much better digital graphics. It's not new. When I started anesthetics in 1992, we had a much better digital graphics. I'll show you in a moment. And they've been demonstrated to improve detection and response times, and they've been evaluated in all sorts of scenarios in medicine, in emergency centers and ICU, operating theaters, cardiac units, and patient transport as well. And I think there's even ISO standards that point out that they need to be highly usable and to take into account human factors. So how could we do this? And this is where we go back to the future, really. So in the early 1990s, Omida had the Omida Modulus CD, which was a production machine that they sold in Europe, certainly. And really what they do is they take advantage of the human's natural ability to detect changes in color and shape. And therefore, they can convey relevant information effectively and efficiently, much more so than with just numeric displays. And they've been studied in these complex, high-risk and data-rich environments like in aviation. Think about it. When the pilots are flying, we all know that they have that dial that tells them where they are on the horizontal. They don't just give them a number on a dial. They actually show this is the angle that the airplane's flying at. And similarly, in power plants, they use graphical displays, and in healthcare, it's been shown to make a difference as well. So it's interesting. The meter modulus was launched in the early 1990s, and then they withdrew that feature after a few years because very few customers were using it. And this is how you could pick to use the data. So there was an integrated screen that would pull the information because the basic vital signs were all on the, including capnography, were all on the anesthetic machine. And you could see it in a numeric way like this, or you could see it in a histogram like that, where you once you had set the ranges that were acceptable or your alarm ranges, you then could see where the bobbin fitted in the dark patch in between, and you could see if they were approaching your ranges that you didn't want them to be in. So that was one way. But the one that I found very useful was the polygram. And this was basically just a shape like that. And when you were happy with the patient at the start, you would just press a button and it would take all the vital signs would come out and make a polygram. And then there would be these spokes that were, you could then set the alarms either tight or you could set them more lax. And then they would change the length of that spoke. And then what happened was that if the heart rate, like on this thing, the heart rate has slowed down from the rate that they'd obviously set, is that what happened was that the shaded part would become different shape inside that polygram. So you'd always see the polygram, but you'd see now something has happened here. And you can see on this side, the tidal volume is slightly less than when you had started it. And maybe the CO2 is a little bit high here. And that would flash every 2 or 3 seconds. And you, just by looking at the shape, you could say, nothing has changed in this patient. Nothing has changed. Or suddenly something has changed, or 2 things have changed. And you could see that. And so it was a very visual way of just looking at all of your data without looking at a list of numbers that you might see. And this, I think, just some other groups' way of presenting similar kind of data, but this is just looking at the cardiovascular system. And the top picture here with the CVP, so the central venous pressure, is on the blue, and the mean arterial pressure is 90 on the right, and the systemic vascular resistance is demonstrated by these diamonds. And then there's the cardiac index, which is made up of the stroke volume and the heart rate. And so what you can see is that in the bottom one, with just looking at that, you can see if I taught you in a minute or two, you'd recognize that the venous pressure is down. It's not filling that block anymore. Whatever the numerical value was to start, you can see it's down. And also the cardiac index is down. That full circle is no longer there. And if you look at it, you could then see the heart rate's unchanged. It's the stroke volume that's down because of the CVP that's down. And then the mean arterial pressure doesn't fill the block either. And the systemic vascular resistance has gone up. And so just a simple digital representation allows you to interpret a whole lot of things about the system that numerical values would be much more difficult to tease out what is happening in there. And then you can get much more complex. So you can look at not only what's happening to the vital signs, but actually where you are with different drugs as well. And there's an idea that these sort of ecological displays would be the next level up, where you depict the relationship between the different elements. So on the bottom right here, you have there's oxygen saturations are 100%, but in that same thing, the things that account for that are the cardiac output, which is 5.5, and then the oxygen carriage in the blood, which is 20.4. And so you can see what is making up the saturation. So it depicts that relationship. So these things allow you to understand much more, much quicker than just having numerical values. So why haven't we changed? Because as I said, Amida put it in and then they took it out because people weren't using it. And it's the classic human thing. You know, if you've got something that's working, even if something may be better, you know, you have to understand why. The push factors might be that there are problems with the normal one, so it could be better basically. And then, but you also have to understand what the better things are that would pull you towards changing. And then what you've got to overcome is that inertia, that we're all so familiar with the one thing, And we're also a little bit anxious about change. And so that is the reason why we probably are left exactly where we were probably 30 or 40 years ago with monitors. So I think we would do well to consider actually what do we want, and should we not be pushing to change things? I think they're well studied. We've moved from separate vital signs to the so-called integrated monitor, but actually it doesn't do anything different. And integrated graphic displays really probably have the potential to enhance patient care. And the studies so far support that actually you'll get better patient care. So, but what we know about them so far, about the studies, is they're mostly small. They haven't all shown improvement, but they definitely show that you detect problems better. But there's a huge potential to show an improved outcome in patients. So I think this is definitely an area where anesthesia could provide some kind of impetus to the companies to change. The other thing is hands-free. I mean, if everywhere you go, people are using hands-free devices. I mean, you get into people's small little European cars and there's a head-up display in front of it. Fighter pilots use head-up displays all the time. Factory workers use head-up display because it allows them to perform their work and to know what the next step on the task is and to identify what they should be doing. And in anesthesia, it would be fantastic if we had Google Glasses kinds of tools at hand, because when we're intubating, you're then concentrating on the patient's airway, but the vital signs are somewhere else and you don't know what's happening. Similarly, when we're putting in arterial lines or checking blood, they're typically in patients who are unstable or who are sick. And whilst you focused on that task, if you could see what the blood pressure and the heart rate and the sats were, it'd be very, very comforting actually for us. And it's such simple technology and it's available everywhere. So I don't know why we haven't moved yet. And the next video comes from, I know, as I said, the factory workers are using it, and there's quite a lot of work showing that actually it makes them more effective. They use stuff better. They do stuff more predictably better. And so why aren't we doing it? And this next video comes from Philips. So I'm not sponsored by Philips, but it gives you an idea of what could be.
Okay, Glass, patient status. Okay, Glass, check vital signs, bed 4. Okay, Glass, increased SIVO, 2%. Very cool. I've been reading about it. I wanted to see what it's all about, and it was even better than I thought it would be.
Yo, I wish I had that. I would say exactly what he said. I've been dreaming about Google Glasses for ages. So I think, yeah, we've come a long way from the 1970s with our monitors. We've stacked them up. We put them into integrated monitors, and that's what we've been sold. But actually, I think there's a lot of things that we can get better with. Firstly, as anesthetists, we must make sure we use peripheral nerve stimulators more and better. The process EEG is an interesting space, and it hopefully will provide an ability to tailor anesthetic dose much better to individual patients. Intelligent alarms have got to be so simple for us to get, and will frustrate us less and probably make us more sensitive to alarms that really matter, because we'll know that every alarm we should respond to. The improved data display is something, as I said, they've explored it before in anesthetic machines and taken it out, but the rest of the data in various parts of medicine is there that actually improving the data with graphic displays improves the how people pick up changes and how they respond. And I think it's something that we really should be thinking about. I just pray that we can maybe go cable free sometime and free my colleagues in the future up from having all these tangles of cables. A head-up display is absolutely zero risk in something like that, and it must be doable, and is something that is certainly for me it would be a dream. And really, I don't know, what I often hear from companies is that we can network all your data, we can tie the machines up, you can centralize, you can take all your vital signs ever into that. And for looking after individual patients, that kind of ability, that kind of computerization and sucking of data, just because you can do it, it really provides very little benefit to people who are clinical anesthetists. That is something that research groups are maybe interested in, but it's not the kind of stuff that that people are interested in healthcare are interested in doing. So yeah, hopefully I've given you a few thoughts. Maybe some of them a bit controversial, but yeah, thanks for listening, and I'm happy to take any questions.
Thank you very much, Anthony. Yeah, that's really, really interesting. I think we're going to open up with a couple of questions. If there's anybody, if you can perhaps just indicate by hand if there's anybody that would like to ask anything to Dr. Reed. Um, Winston saying, thank you, love the concept of the Google glasses. From a maintenance point of view, we have major issues with mobile medical items being easily lost and damaged. I think it's just a comment from Winston's side in terms of, taking care and protecting the asset over the period. Monard is asking, would you prefer NMT over BIS?
NMT, what's the
Monard,
neuromuscular transmission, isn't it?
yes, over BIS.
Which one would I prefer?
Yes.
So is a neuromuscular blocker
Neuromuscular transducing over BIS. Would you prefer neuromuscular transducing over BIS?
Yeah, so I mean, monitoring muscle relaxants is absolutely essential monitor. Whereas a depth of anesthesia can be monitored in several ways. I'm not sure, am I missing something here? Because they're kind of different things. If I had to pick one, there's one's absolutely essential and one's a nice to have.
Let me see. Monard, would you like to, where's Monard? Let me see if I can unmute you. Then you can perhaps just give me 2 seconds. Where's
I said
Monard?
neuromuscular transducing. I'm just Monard. You can ask me a question.
Hi, Dr. Reed. Hope you're well. Can you hear me?
Yeah, very good. Thank you. Yeah, go for it.
So basically, as you know, we've got two options. We've got a neuromuscular transducer system, and then we've got a BIS system. Which would be more relevant to
So what are they using
anesthesia?
neuromuscular transducing for?
They're looking at, especially the train of 4, to see if there's any pulse, if there's any neuromuscular activity, especially if they're doing paralytic agents.
That's the peripheral nerve stimulator. And that measures, it's an absolutely essential monitor if you're using a neuromuscular blocking agent. And so the neuromuscular monitors, I saw Leon also said he didn't realize how important they are. But so the thing about them is that when they were introduced, when nerve stimulators were introduced, we used to have a recovery ratio of 0.7. So the fourth twitch in a train of 4 had to be 70% of the first twitch. And then it was thought that you had adequate power to look after yourself. And that was in the early 90s, that was still acceptable. But what they found is, in fact, that you need to have a recovery ratio of 0.9 to prevent microaspiration, because the muscles that are most sensitive to the neuromuscular blocking agents are not in the hand, which is where we're typically measuring it, or on the sides of the face, but actually the around the larynx. And if you didn't have a recovery ratio of 0.9, so it was up from 0.7, is that what patients had a microaspiration, and they would get post-operative respiratory complications, and some of them would die as a consequence of that. And so unless you're measuring that, and the problem with that is that you don't know, by the time they have a ratio of 0.7, they can lift their heads up, they can squeeze your hand tightly, they can do all the other things, they can cough well. The problem is they don't have, unless you measure it, they don't have the laryngeal function. And then they have microaspiration and they get those problems. So that's an absolutely essential monitor. So if I had to pick between the two, I'd absolutely take it, because there are other ways of working out how deep a patient, if the patient's getting enough anesthetic or not. And an end-tidal anesthetic gas would be the first point in that, but there are other ways you can do that. But yeah, so if I had to pick, I'd definitely pick a peripheral nerve stimulator or a neuromuscular transducing.
Oh, thank you very much. That answers my question perfectly. Thank you, Doc.
There you go.
Cool. Thank you, Monat. I don't see anything else in the chat. Is there any? Okay, there's a question. How do we change the mind of anesthetists when doctors prefer one model over another for the same technology? For example, BIS over Connox.
That's quite difficult because people, I mean, people like it's that classic picture that I showed. Is that how do you change people? It's those push-pull factors and what makes people, because they become comfortable with something, and we all have that, and that's and I think, I mean, Connex does some different things to BIS. So BIS is very specific. And BIS is, because it's so dominant in the market, it's quite difficult to try and persuade people. But I think one way is to get people who are champions, who really enjoy using that piece of equipment, and you can speak to the good things and the bad things about that compared to other things. So I think the thing about BIS is that so many people got used to it that they know it, and if you give them something else, it's just more difficult to find their way around it. For those kinds of process EEG things, I mean, many people will know I'm a bit biased towards Entropy because their software is open source. So then there's no black box. We understand the mathematics behind how they achieved a value, although we don't attribute much attention to the value. But the fact that they were open about it was quite attractive. But I think for me, the bottom line is that we wanting, so when we're looking at processed EEGs, I think what we're trying to do is look at the raw waveform. And so all of these monitors give us that raw waveform. And if you're really interested in it, you want to look at that, and then you want to try and interpret that and see what waves will be within that. And there are various other parameters that they give us. And that is and that the thing about it is that what BIS have done very well, and the other monitors now, is by giving this DSA, it's kind of a lazy way of presenting that data. But my worry is that if people see that, is that they don't actually understand what they really should be looking for, which is actually looking for where is the power, in what frequency does the power lie. And I think, yeah, I mean, I don't know, like if I was a rep and I was the Connox rep, I mean, I think I would try and get some established players who could give a good account of your machine, because I think you're just basically going on familiarity and people's comfort with it. And if you can persuade them that certain individuals are comfortable with it, I think that would be very useful.
Okay, thank you. Mohammed, excellent presentation. Well done. We as clinical engineers need to get end users input more often to understand the needs. Well done to Kisa team for organizing the talk. Cool. Thank you, Mohammed. Okay, I think we can. Okay, here's another question from Gert. Great presentation. Much appreciated. Just a comment rather than a question. Certain wireless monitoring already available, like ECG, SpO2, NIBP, and temp. Also, advances have been made in alarm management for induction.
That's interesting.
Okay. So that's something that we can definitely look at.
Speak to me, Gert.
Okay, thank you very much, everybody. I think we can. I've got a hand up here from Philippe. Yes, you can go.
Thanks, Carl. Dr. Reed, I just want to say great presentation. You took me back when you showed me the Modulus XL anesthetic machine, way back when. It was good to see that unit. I also like the idea with the heads-up displays and the Google glasses. My point was also to Gert's point towards the wireless units that they've got, or solutions that they're bringing out there at the moment. There's quite a few units that they're bringing out. I think the major hindrance that they're finding is that there's quite a bit of noise in theater. So they need to use like specific, either, let's say they call it USB or specific wireless LAN frequencies, so that they don't get the interference from the rest of the equipment in theater. But there's quite a bit of movement of that at the moment.
Yeah, no, I mean, I think it's ripe for people to move into, but I agree. There is a lot of electromagnetic interference in operating rooms, But as you point out, is that there's certain maybe frequencies that are completely clean, and maybe that's where they need to be playing with rather than in the more busy frequencies. But yeah. So I mean, I think Carl Dicoletti has got an interesting question there. And are we at risk of introducing technology and anesthetists don't look at the patient? And I think that's a real concern, is that you can get too fixed on certain aspects of monitoring and miss the fact that the very basics are being ignored. And so that's a real thing. So I think those of us who train anesthetists, we try and make sure that they focus first of all on the patient and the things that really matter to the patient, and then the other things. But technology can definitely distract you from good patient care. At the same time, it can help you to better do your job if you use it correctly. So I think it's a bit of both, but I think you're right to be worried about people being distracted. And certainly people using transesophageal echo, single operators doing that, they can often become quite fixated on those and trying to get good pictures there when actually there's a patient who's anesthetized that needs care.
Okay, great. Thank you very much. Okay, that's it for today. Thank you very much again, Anthony. We really appreciate your time and efforts. We know that you are extremely busy. So thank you very much. Thank you everybody for joining in. And if you are in Cape Town and in the Garden Route, please stay warm and be safe in the winter time. Thank you very much.